Good morning. My name is Ann Brazo. I'm the founder and CEO of MPN Advocacy and Education International. We have been hosting conversations with MPN specialists for about 3 years now, or ever since the pandemic. It just seemed to be the best thing we could do to reach MPN patients during that time when we were isolated. And we've carried this on because we've had such a great response from patients. They're able to join us online instead of in person these days. And with us today is Dr. Ellen Ritchie from New York City at Weill Cornell. Ellen has spoken at many of our events, especially our women's events, and has been with us on different webinars. She's done excellent work in cardiac health and MPNs, especially for women, but for all of us, for everybody. And she is just here to answer your questions. And so fire them our way, and I will ask her, and we will have a wonderful hour with Ellen. So, Dr. Ritchie, your first question is, thank
Okay.
you, first of all, for being here. We always appreciate you so much. This comes up quite often, and it's about vitamins or supplements. And should this person be taking vitamin D3 supplement? They are an MF patient. Every doctor they speak to has conflicting views about this. And so we're going to pose that question to you.
Well, supplementation is a big topic. And, when it comes to vitamin D, it's actually something that's measurable. So that when you visit your primary care doctor, it's often part of a regular primary care visit that they measure your vitamin D level, especially if you're a woman and you have risk factors for osteoporosis. Your family members have osteoporosis, your mother did, your grandmother. Whether you live in a place which is sunny or whether you get outside, if you're going out and playing golf every day in Florida, it's a little bit different than on the 42nd floor of a building in New York City, where you are in the middle of the floor all day long.
Mm-hmm.
So that your primary care really needs to take responsibility and to measure your vitamin D. In measuring your vitamin D, you can find out whether your levels are low or whether they're too high. And there's such a thing as too much vitamin D also. So you want to make sure that that you have a normal level. And based on what your labs show, your doctor will decide what the best supplementation route is for you. Do you need high dose vitamin C? Do you need just our vitamin D or regular vitamin D daily? Or do you not need any at all?
Mm-hmm.
They may also go forward and screen you for osteoporosis, do a DEXA scan, or look at your bone health and decide based on your bone health whether there are any adjustments they'd like to make.
Yeah, and living in the Northeast and the middle of the country, I remember a doctor saying to me, because at one time I had low vitamin D, and he said, just sit out in the sun, whether it's 40 degrees or 70 degrees, for a half hour. And honestly, it just brought it right up. It just shot right up. Now I do take vitamin D supplement, but I just do that daily. And I basically, during the pandemic, when the pandemic first started, I remember Dr. Fauci, really hitting home, take vitamin D. And I've never had COVID, just to let you know. I've been vaccinated a million times also, but anyway, also, all right. So everybody wants to know what causes the itching and what they can do about it.
The itching is probably based on cytokines that you're making or inflammatory cytokines that you're making as part of your MPN. Exactly what cytokines are involved in the causing of itching per se, I can't tell you for sure. I don't think we really know the answer to that question. If we did, we'd have some beautiful targeted therapy toward itching, I think. But it's part of the inflammatory cascade. There are antihistamines or things like that, which traditionally work against itching, don't work as well in patients who have MPNs. And really, the important thing is to get control of your disease, control of your blood counts, and that's really the key to lessening the aggravation of itching. Certain medications for MPNs may be more relevant to relieving that symptom than others. And it's something that you should talk about with your physician. Itching can drive you crazy, and it can really cause misery for patients. You should be vocal about misery if it has come your way, and you should talk with your physician about different strategies which could be used to maybe mitigate that. This may be a symptom that talking to someone who's an MPN specialist may be helpful, because we see more of that than almost anyone, and can give you sort of a sense of how the medications are working against this symptom, and whether any of the new medications are any better than some of the older medications
Right.
against this particular symptom. So, it's something to really, again, discuss with your doctor.
Yeah. And, it's just so heartbreaking when you hear from someone that is having such an issue, after showers. And so they recommend a cool shower. And, just somebody was telling me recently that they just touch their hands sometimes or touch their arms and the itching begins right away, so that has to be devastating. Is there anything this patient can do to help a fatty liver and spleen size? They do not drink alcohol and they are on Jakafi.
So,
Interesting.
fatty liver can be caused by lipid abnormalities. They can be caused by obesity. So losing weight might be a key to helping with a fatty liver. There are one side effect of Jakafi is an elevation in your cholesterol level. So when you are on Jakafi, you need to have your cholesterol level monitored regularly. You may need to go on medication for elevated cholesterol. And certainly, you want to guard against high levels of cholesterol and protecting yourself against a fatty liver. There are one of the sort of exciting potentials of these new drugs like Ozempic is that it looks like these types of drugs may also have activity against fatty liver. And there are clinical trials which are ongoing in patients who have fatty liver, where they are looking at these classes of drugs and trying to prevent some of the complications. So that's if you do have fatty liver and you've been referred to a hepatologist, that may be an option for you.
Mhm. And this is just a question off the cuff, and that is, I hear differing views on the number, the total number for the cholesterol score. And in MPN patients with some issues, what is the number that you want your patients to have when it comes to cholesterol?
I mean, you're really looking for your maximum cardiac, your cardiovascular preventative, number. And that's
Mhm.
really an LDL, which is your bad cholesterol, of 100 or less. So, it's not so much what your total is per se. If your HDL, which is your good cholesterol, is high, it helps offset things a little bit, but you really want your bad cholesterol to be 100 or less.
Mhm. We always hear about bone pain, and this question is there a way to differentiate bone pain from an MPN versus rheumatoid arthritis?
Rheumatoid arthritis is very different. It really is a pain which is more concentrated in the joints, not the bones themselves. So it's often, rheumatoid arthritis is an inflammatory condition of the joints where you're destroying the cartilage, which is the lining, between your bones at the joint space. So it's inflammation in that area. So, it's very commonly in the tiny joints of the hands or the tiny joints of the feet or the knees or the hips. So it's really a joint pain. Now, like MPNs, rheumatoid arthritis often gives patients a higher level of cytokines or sort of an inflammatory picture. And patients who have a flare of their rheumatoid arthritis might feel a little bit like they have the flu, with sort of body aches and joint pains. But it's a little bit different than bone pain, which comes from the fact that you have too many cells in the bone marrow that are pushing on the inside of your bones, pushing toward the outside. And that's putting pressure on the entire bone. So that's your entire femur might have field pressure or pain. So it's an achy pain, basically, of the bones, which is a little bit different than joint pain. But like a patient with rheumatoid arthritis, you can have, what is sort of like a flare where your cytokine levels are high. You feel a little bit like you have the flu. Maybe you have some low-grade fevers or night sweats. And these are things that those two diseases can have in common. They're both inflammatory diseases, but they come from a very different space. One is a problem with the bone marrow, and one is a problem where your immune system is making antibodies toward your normal tissue, which in this case is your cartilage.
Wow. Great response. We hear it all the time, and that's another, sad symptom to having an MPN. And
Both MPN and rheumatoid arthritis, I feel sorry for those.
yeah, I mean, both of them are just terrible. How do women differentiate between menopause and MPN brain fog?
Menopause is certainly more ubiquitous. It's everyone goes through it. You're not exempt from menopause. Menopause usually comes as a constellation of symptoms. So again, night sweats, heavy bleeding, then followed maybe by no bleeding. The brain fog of menopause is probably not so different than a brain fog from an MPN, except for it's timed at the exact period of your menopausal space. And it's usually in combination with those other symptoms of menopause, which is, everything from weight gain to poor sleep to hot flashes, to all those lovely things that happen to women. If you are in the age of menopause and you're feeling those symptoms, there are potential therapies for that. And you can talk to your OB-GYN. They do hormonal therapies are common. There are different ways that hormonal therapies are administered. And you can talk to your GYN about that. And maybe deciding to try one of those therapies might mitigate some of those symptoms for you and make you feel better. The therapies for menopause are not necessarily going to make you feel better if you have brain fog from a myeloproliferative disease. So it's worth talking to your GYN about.
Yeah, in the brain fog, if I'm 30 years old and am having brain fog and night sweats, it probably isn't
It probably
menopause.
isn't menopause.
Right.
Although
Right.
it can happen that you have
Yeah.
menopause. So it's always reasonable to talk to your GYN about that if you're concerned about that.
Yeah.
Very easy to investigate whether that's happening. So if you're concerned or have a family history of premature menopause, or you're concerned about your fertility and that's what you want to talk about, then make sure that you involve your GYN.
Definitely. What would you recommend for an ideal hematocrit level? Mine hovers between, this is the patient, between 41 and 44, and my doctor wants it under 42 and wants to increase my Jakafi.
So there's a little bit of controversy
Yes.
that occurs about the optimal hematocrit level. And it's practitioner dependent to some degree. It's also based on evidence to another degree, but There are certainly, we know that you want your hematocrit to be below 45. So if you have polycythemia vera, you have an MPN, your hematocrit is best below 45. Women generally have lower hematocrits than men do. And there has been a real thought process that women should have a hematocrit of 42 or less, as opposed to men really at 45 or less. And, as I said, it's somewhat controversial. There is evidence for this, for the lower hematocrit in women and keeping it a little bit lower, but not everyone actually adheres to that. So you have to have a discussion with your doctor, I think, about the evidence and about how you feel. When you are first diagnosed with an MPN, in that first year is really one of the highest likelihoods that you're going to develop a thrombosis. And so keeping your hematocrit, lower that first year might be something that your practitioner really believes in, and you should discuss it with them. And also discuss with him how you're feeling with phlebotomy or on Jakafi. And, are they using phlebotomy plus Jakafi? How are you being maintained? And are you iron deficient? And is that iron deficiency playing a real role in how you feel? So all of these things are things that need to be discussed with your practitioner as you discuss the appropriate level for your hematocrit.
And we heard a lot, in the 21 years I've been in this space, I've heard so many people talk about migraines. And we actually did a survey from our organization, and determined, or, from that survey, was mostly women that suffered the migraines, all different ages. And it was mostly PV, as I recall. Can you talk to us about migraines and MPNs? And this person has debilitating migraines. They're on Jakafi. They have ET. ET was another one of people that had migraines. They're on Jakafi and taking hydroxyurea, so a combination of drugs. Is there any herbal remedy they can take? I'd like to stay away from more pharmaceutical pills or injections.
Well, migraine is a very complicated disorder. Certainly it's associated with myeloproliferative diseases, that having high platelet counts or high hematocrits or even a high white count can certainly contribute to migraine. But there are hormonal issues which contribute to migraine. We talked about menopause a short time ago. There are some women who get migraines as part of their menopausal symptoms. And it's a neurologic event that occurs in the brain, where there is a sort of cascade of neurologic events which result in migraine. Now, migraine can manifest itself in all sorts of ways, pain, nausea, vomiting. It can also give you symptoms like auras or visions that are maybe unpleasant or unwanted. And, it can be very difficult. There isn't an herb which is going to actually manage this complicated neurologic problem. There are many new medications out for migraine, and, they include, some people are using botulinum toxin, some people are using new, more targeted drugs for migraine. But depending on how bad your symptoms are and how often you get them, it may be that you need to think about some sort of pharmacologic therapy to protect you from being not functional in your life for good portions of time. So if you're having migraines and you're being optimally controlled, your blood counts with your MPN regimen, it may be worthwhile that you discuss this with a neurologist and try and figure out what other triggers you might have, how you can act on those particular triggers, And if there are medications that can nip it in the bud, what might be best for you?
Mhm.
As I said, they can occur as part of a menopausal type of symptom. So that, that's a hormonal trigger, actually. And you can begin to sort of figure out when those headaches might start to occur and prophylax a little bit against those. So it's important to figure out what your triggers are and to try and manage them. That's the most effective non-pharmacologic way to manage migraine. But if you're out of your life because you're having pain, nausea, vomiting, other symptoms, you may need something more aggressive to help you get through these periods.
I know that interferon can cause side effects, and one of the side effects is a headache, or headaches. But I also know a few women that went on Pegasus or Besremi, and their headaches went away. So
Well,
can you explain that a little bit?
I don't think that uh, interferon necessarily causes headaches.
Oh, okay.
I
So,
I think it's probably the underlying disease, which is is the problem more than anything else. Besremi is an excellent interferon. So if you're controlling your blood counts optimally, and we think that it's your MPN, which is really the trigger for your migraines, then your migraines may go away,
yeah.
and that's great. But there are patients with MPNs who have migraines who, even with optimal control of their blood counts, continue to have headaches. And there may be something more to their migraine disease than just their MPN.
Hmm.
Jakafi can also cause headaches. There are some people who get headaches from Jakafi. So that, it all depends on the person and their sort of their reaction to medication sometimes that will govern this. But in general, I think for MPN patients, it's the underlying disease, which is one of the triggers for migraine.
Hmm.
But there can be other things going on. So, you need to make sure that there are not other triggers that are in your life that are making your migraines worse.
One question here is about birth control, and that they're also on birth control and pills, but they never had migraines prior to birth control pills. So if I'm an MPN patient and I'm on an oral birth control pill and maybe on Jakafi or something else, um, I remember back in the day, you friends saying, "Oh, I get horrible headaches from, I think it's from the estrogen or whatever." Are you, do you see that as well?
Well, certainly there are patients who there are many, many different types of preparations of birth control with different proportions of estrogen and progesterone in them. And there are many different formulations. So birth control can give patients headaches, but it may be that you're just on the wrong formulation. And that's something you need to talk to your gyne about, because
Mhm.
it may be one type of birth control will give you a headache, but if they switch you to a different type, you may not have a headache with it. So it's really important to talk to your practitioner
Mhm.
about the type of birth control that you're on. But certainly, birth control pills are a sort of a time-honored cause of headache in patients, and we're lucky now that there are many, many different formulations, so that the gyne can actually try different varieties and that may be more tolerable to you. But
Mhm.
in combination, when you're taking lots of different medications, many medications can be involved in the development of headache. And so it's important to discuss all of your medications, including the supplements you're taking,
Mhm.
with your physician if you're having adverse symptoms.
This person is nervous about bone marrow biopsies. Can I be given any pain medication during the procedure? And I'm really curious about this because I know the University of Michigan is actually has a study going on for doing an MRI instead of aspiration,
Mhm.
But is there something out there that, a patient can ask for?
I often find listening to music during the period time that you're having a procedure that you really like is really helpful. So I would, number one, recommend if you like music and you like listening to music, that you should bring your iPods with you and that you should put on what you really like to listen to. That's number one. Something that makes you feel cheerful and happy and relaxed is probably the most effective thing of all. So I would recommend music as number one, and we offer that to our patients, or I always do when I'm doing a bone marrow biopsy. Pain medicine is, not really as helpful probably as medicine that might relax you. It's really the anticipation of the fact that you're going to have pain, or your worry that you might have pain, which is the most serious enemy sort of for your having pain during a procedure. So sometimes having a person with you who is relaxing to you, in addition to listening to music, or a little bit of medication that might be somewhat relaxing. Pain medicine itself, I don't know if it's that helpful. And pain medicine is really most helpful after you've had pain. So in a bone marrow biopsy, we try and lessen your pain by using lidocaine, or using something to numb you or prevent you from having pain prior to the procedure. And just like the dentist, if the dentist gives you Novocaine and doesn't give it a time to set in, but decides to start drilling before you've let the Novocaine actually dwell there, you can experience pain because the dentist is in a hurry. Same thing is true for the person doing a bone marrow biopsy. You got to let the lidocaine sit there for a second and have an opportunity to work before you start doing the procedure. So, making sure that it's all done, it's not done in a big hurry, that it's done in a way that, is slow and steady wins the race, and that sort of situation. There are no one wants anyone to experience pain during a procedure. It's pretty hard during almost any procedure to avoid that completely. Even when you have a surgery, they're going to put an IV in, and you're going to have, the discomfort of that experience, with the IV before the anesthesia goes in. There are institutions that are experimenting with things like using interventional radiology for a procedure. But there's always a risk anytime you're using anesthesia of other complications that can occur. So, it's sort of a risk benefit balance in a lot of situations.
Yeah.
So, my go-to as the safest and easiest way to try and prevent pain is music, having someone come with you who's relaxing and helpful for you, and not going too fast when the procedure is ongoing is sort of the first steps. And if those are not successful, a little bit of medicine to help relax you before the procedure.
Yeah. I've heard some patients say they take, what are some of the, like
A
not
little
Vicodin, but
Ativan or a little
yeah, Advent. Yeah, some of those things beforehand. I'd probably hallucinate, so it would not be good
Well,
for me.
and these are things that can happen, right? Or
Yeah.
people can't get up off the table, or
Gee.
things can happen. Anesthesia is not without its risks also.
Mhm.
So everything has a risk.
Yeah. Yeah. So two very good questions here. What is the best way to reduce inflammation? We've been talking about this now for several years, when, some of the studies have really talked about inflammation and MPNs. And we've talked about diet, we've talked about other things, but can you share some other ideas in terms of, reducing inflammation for MPN patients?
Inflammation is again a complicated uh, uh, situation where it's your immune system or your that's really in overdrive, and that's what causes inflammatory processes. But there are many aspects of modern life which cause inflammation, pollution that are well beyond our control.
Yeah.
Pollution, stress, a harried lifestyle, reading the newspaper, any of these things, can contribute to inflammation. And all of these things are really beyond, a lot of them are beyond our control.
Mhm.
And we're learning more and more about the environments we live in, polluted cities, crowded cities, these things cause stress to a living thing and cause an inflammatory processes. So I think you need to find everyone for themselves something that brings them down to a more manageable level of stress, and that is really something that's underutilized and not thought much about in terms of regulating inflammation. We haven't really looked, I think, strongly enough at things like meditation, exercise, um, you know, regular social interaction, not just at the telephone.
Yes.
Things that where you're taking things down a notch, are probably more helpful than we think
Yes.
in lowering the burden of inflammation. You can read ad nauseum about anti-inflammatory diets. Certainly I think that the less processed food you have in your life, probably the better for you. If you cook and make your own food, you probably are ahead of the game. If you're not eating a lot of processed food, you're probably ahead of the game. If you're getting decent exercise, if you're not smoking, if you're not drinking too much, if you're not using drugs, that's probably very good for you. And that you need to figure out ways for yourself to bring down that level of stress. I mean, this phone is a lot of stress for a lot of people. So making a decision, am I going to have two phone-free hours during my working day? Maybe that brings down the level of inflammation. We have a lot of work to do, I think, in determining what strategies that we can create that lower the level of stress on a living thing and lower the level of inflammation.
I totally agree 1,000%. And we do have, Natalie has been doing yoga and meditation and breathing classes for our MPN patients and webinars, and she will there's going to start again, I think next month, correct? Or next week. We have a series starting again, so join us if you're able. But I agree with you. I mean, the processed foods, all of it. And there are studies after study after study about the need for nature or green space. Even in New York City, I love Central Park. I love some of the other parks in New York City. But that I am one of those people that absolutely needs green space. And getting back to, just listening to birds instead of a phone and people and, but thank you for that. What should this patient be paying attention to in terms of progression?
I think that the most important thing to look at is your functional status and how are you able to do on a given day everything that you want to do with that day. So are you able to get up? Let's say what you want to do is get up and go to work and have a social time after work for an hour. go home to the gym and go to bed at night. Let's say that's what you want to accomplish during the day. Can you do that? Are you able to do that? And if you're not able to accomplish what you need to accomplish during a given day, you have to ask yourself, why? Is it because I'm not feeling well? And am I unable to accomplish things I need to do in a given day because I'm not feeling well? I'm not motivated. Actually, I don't really like going to the gym, so I don't want to go to the gym. Or is it that I just don't have the energy to do this? Or I just need to lie down, or I can't do this. So you really have to ask yourself, if you're not able to do the things you need to do, why? And is it because you're not feeling well? And if you're realizing that you're skipping more and more things and you're doing less with your day than you would like to, if you are not able to have social interactions with your friends, if you're skipping them, if you're canceling dinner dates, if you're canceling, you don't go to the theater anymore, you don't go to the gym anymore, you don't do things that you really like to do, well, is it because you don't feel well? And if you're not feeling well, then you might be progressing and you need to talk about it with your doctor. Why am I not able to live up to my own expectations for myself? And that's amongst the most important things. I have an older lady who realized that it just got too hard to do laundry. Her laundry was in the basement. So she had to walk down to the basement, do her laundry in the basement, and then carry her laundry back up to the floor and fold it. Well, it turned out that that just was really too much for her. And so she stopped going to the basement and she stopped doing her laundry and she started doing it in the kitchen sink upstairs, right? So she was realizing that she's doing less and less. And then she realizes, well, you know what? Her shower is on the second floor. She didn't feel like walking up to the second floor and taking a shower every day either. So this lady was progressing. Her MPN was getting worse. She was more and more tired. She had much less energy to do the things that she needed to do in her everyday life. And by the time she came to her 3-month follow-up appointment, she hadn't been in her basement in 3 months, and she hadn't been to her second floor in 2 months. She hadn't taken a shower in a long time, and she hadn't had the energy, to take care of herself. So clearly she was progressing, and she was progressing. So when you're unable to do the things you need to do to take care of yourself or to enjoy your life, you have to ask yourself whether your disease is progressing. There are more obvious things too. If you start developing fevers every single night, that every single night you're 100.3, 100.4, or you're waking up in the middle of the night with soaking night sweats and you're soaking your sheets, soaking your pajamas, that, something is happening which is unusual and new for you. And that means that you should probably check in with your doctor and see if something is happening. Or if you're losing weight and you're not trying to. If you're eating ice cream every night, but you've lost 10 pounds, there's a problem. And that you need to talk it over with your physician. So when things like that happen, that you're not able to take care of yourself, to lead the sort of life that you envision for yourself, or you have a frank symptom which is new, that's a reason to be concerned about progression and at least check in with your doctor.
Yeah. And then when they check in with their physician, would the blood work indicate, something changed or?
Well, blood work is part of a good examination. I mean, I think a good exam requires a conversation with your doctor about what's different and what's new. The conversation should then extend to any new symptoms that you're having. And you may have symptoms you're not really recognizing until your doctor asks you specific questions about them. A physical exam is part of the process. Have you had a non-palpable spleen? that suddenly your spleen is palpable? Or is there something else on physical exam, like your heart rate has always been regular and normal, but today it's irregular and it's not sounding like it normally does? Um, that's an important part of a good physical exam. And lastly, the lab work. So all of these things together, should be like puzzle pieces
Mhm.
that fit together and give you a clue as to whether or not there might be progression. You sometimes can see new symptoms or new physical exam findings that aren't reflected in the labs yet. So that's why it's so important to have conversations and discussions.
Mhm.
Um, you know, Otherwise you might as well see a robot. The robot can take your labs. The robot, it can listen to what you have to say, but not process it potentially, or and not interact with you. The reason you see a person is you're hoping that that person actually talks to you, has a conversation with you, and tries to fit these puzzle pieces together.
I love that. I thank you for saying that because I'm sure you're aware of the study. I think it was done 3 or 4 years ago. What does the patient expect or want from the physician and what the physician tends to look at when they meet with the patient? And 9 times out of 10, the physician was looking at blood work and, all the science,
Mm-hmm.
information, and the patient was feeling like dirt. And so I love what you said, talk to, and there are so many other symptoms that are now being shared among MPN patients. And we hosted a patient advisory council meeting, and everybody in that meeting said, oh no, and I have this, and I have this, and I have this. And they were young people and middle-aged people and older people. They, very, very different, and a lot of different things happening now that we didn't pay attention to in the past, I don't think. But I love that you said that because you do need a doctor or that is going to listen and pay attention to what you're telling them. Um, what causes fatigue in MPN patients?
Well, fatigue is one of the most complicated symptoms I think that there happens to be. Um, you know, uh, if you ask any person almost how they feel, most people are going to tell you they're tired. And I think that that's part of the modern world right now, that people are tired and it's exhausting. The level of news, the level of information, the just the pace of the world is exhausting. Fatigue that's actual, cancer related fatigue is much harder, I think, to really characterize. I have a sister who's recently been diagnosed with cancer, and her only complaint for the past 6 months has been she's been a little bit tired. But we never would have thought that a little bit tired would equal stage 4 cancer.
Sorry.
So, that it can be very, very difficult to actually tease that out. We don't really know what causes that profound fatigue that can be associated with cancer or with chemotherapy for certain cancers. Chemotherapy for lung cancer, colon cancer, things like that can be very exhausting too. And we're not really sure how to mitigate that. We wish we had therapies for that type of fatigue. And the only therapy we really have is to get rid of the cancer.
Mhm.
And easier said than done.
Yeah.
Um, I think that one important aspect of managing fatigue is to pace yourself. And that if you do have fatigue that's related to cancer of any kind, to understand that you're not going to be scaling Mount Everest. That's not going to be, that you have to make manageable goals for yourself and to be able to reach those goals. And, I have cancer fatigue, MPN fatigue is certainly a fatigue that is unique, but it's pretty broad to all cancers, that there is a real sense of exhaustion that can be associated with them. And I think the most important thing is to be realistic with yourself as to what you can do and prioritize what matters to you. So if what matters to you is you spend time with your family, don't waste your time cleaning your kitchen. Make a priority as to like what the most important thing is for you and how you want to spend that energy. And that when you're thinking about therapy, you are going to think about a therapy that will be most effective potentially in giving you a higher energy level. And if that's what it is that matters to you, is that trying to figure out with your physician what that best therapy might be.
Okay, I have 4 questions, and I'm very sorry about your sister's diagnosis. And my brother was just diagnosed with CLL. And his first complaint to me was, I'm exhausted. And he's a absolute go-getter. And he said, I just can't, I'm so fatigued. And I said, that is very common, but anyway, I hope your sister's gonna be okay.
Well, it makes me a better doctor, right?
Pardon me?
It makes me a better doctor.
Yes, of course. This person says, how should I handle hormone replacement therapy with my MPN? Good question.
So, what are your expectations from your hormone replacement therapy? And if you're expecting the hormone replacement therapy to fix all of your symptoms of MPN, that's not going to happen. So what are your expectations of hormone replacement therapy? Discuss those with it's usually the gyne who is or the urologist who is prescribing hormone replacement therapy. Make sure that you have a discussion with them as to what your goals are for this, what your expectations are, and make sure that when you initiate the therapy that you're getting what you want out of it.
Okay. Would you recommend that this patient is 80 years old? And would you recommend that they get the spring COVID booster, which I just got?
Right.
And they are taking hydroxyurea.
So 2 things. One, just to back up to the hormone therapy.
Oh, yeah.
I do want to say that it's not recommended for all MPN patients that's a safe thing to do.
Okay.
So it is something you want to discuss with your MPN doctor as well. How you're getting it, through what, is it topical? Is it injectable? How it is that you are going to receive this therapy is very important, and you need to discuss it with your MPN doctor, because hormone replacement therapy can increase your clot risk in certain situations. So you really have to make sure that everyone is on board. And if you're going to embark on it, that you're going to get enough benefit from it that it will be worth any risk that you might be taking. So you want to involve all those doctors. The COVID booster, it is the recommendation of the CDC that patients over the age of 65 have a second COVID booster this year in the spring, really, after having had one in the fall. And this is really based on the demographics of COVID in the last year who died of this disease. And it was really the more elderly patient population that died of COVID. That was really true in the initial COVID too, that nursing homes were really wiped out by those initial COVID infections. So it's older patients that really take on the mortality risk. And it's really based on that mortality risk that the recommendation was made that have another booster to help protect you against any new variants that might arise over the summer or another epidemic of COVID that may occur during that period of time. And so I think was a reasonable recommendation made by the CDC, essentially, to say, let's reduce the risk that patients who are older will die of COVID by having them have another vaccine. That being said, if you've had all of the vaccines, you've had quite a few COVID vaccines up to this point in time. And, there's no real guarantee that, you will not die of COVID, if you have the vaccine. I mean, we hope that you will not, but we don't have, solid evidence about this, about how many COVID vaccines are going to be necessary and what the timing of those vaccines needs to be to optimally protect you against dying from COVID. And we don't really have the answer to that question. I think that if you have other medical illnesses, certainly, if you're diabetes, heart disease, other things that, you really are at higher risk of a mortality event anyway, you really should think seriously about that additional vaccine.
Yeah.
If you're over 65, it's totally reasonable to think about that vaccine because we're trying to, reduce your risk of dying from COVID. And the only way we know to do that is by giving you the vaccine. Mm-hmm. But we don't have the actual answers. And we don't have the real data. For the flu vaccine, we have stronger, data that a yearly flu vaccine, will help protect you from dying of influenza. But, we don't have that data entirely for COVID yet. I think they're going to get smarter about these vaccines. I think that they will end up having combo vaccines, where you're going to get your flu and your COVID all at once. It will be more of a yearly event, and that's probably what we're going to be heading to over time, but we just haven't gotten there yet.
Yeah. So 2 more questions. How do I deal with mouth ulcers or mouth sores caused by hydroxyurea? And I remember when I was at the MPN Research Foundation, and Bob Rosen, who was the chairman, who has since passed, had horrible mouth sores from hydroxyurea. And how do you, what do you tell your patients? How do you treat this?
I take them off hydroxyurea.
You do?
I don't use hydroxyurea if you're having mouth sores all the time.
Yes. And what's the alternative for those patients?
It depends upon the patient, and, I like to think that I listen to what they have to say. I think about making a personalized recommendation, based on their disease and their lifestyle. But we have other choices now. In the old days, all we had was hydroxyurea, but we have other choices now, and discussing those choices, or even, new clinical trial drugs, which might be available, are completely reasonable. And, whether if you're having skin ulcers or mouth ulcers, I generally don't use hydroxyurea.
Mm-hmm. Yeah.
I mean, I certainly, if you are having mouth ulcers, someone should make sure they're not viral.
Yes.
They can be swabbed. They can, we can make sure that they're not HSV or another or a viral infection. If it is a viral infection, potentially treatment would help take care of that. But if they're related to hydroxyurea, if they're not because of infection, then I don't think hydroxyurea is the right drug for you.
Right. This person is newly diagnosed with essential thrombocythemia and then converted to MF. Who should they be seeing and how often in terms of a hematologist or MPN specialist? And, I'm pretty sure your recommendation would be what we would say, but what would you say to that patient?
I mean, certainly it's reasonable to have a consultation with an MPN specialist. An MPN specialist can work with your local hematologist So you don't have to travel long distances constantly, to be able to see the specialist,
Right.
a year. But, the most common model is that we sort of share the care, that, we evaluate the patient, we make a recommendation, we follow with their local hematologist every year or so. We check in with the patient personally and make sure things are going well, but it's more of a shared care type of situation. And given that there aren't large medical centers in every single town in the country, it means that you just have to make that trek once maybe or twice to get a care plan in place. If something changes about your disease, for example, you were diagnosed with essential thrombocythemia, you went on some particular care plan, but then you progressed, that time of progression might be a second time that you might want to check in with an MPN specialist, because there needs to be a change in the treatment plan. And maybe even thought about enrollment on a clinical trial. But I think that it's at those important time junctures that you need to check in with the MPN specialist.
I agree. So in closing, we have 2 minutes left. And first of all, thank you so much for your time as always. What wisdom would you impart to our MPN patients and caregivers, that what are you seeing that looks promising, either in a new drug or in any research that you're involved in or otherwise? What would you like to share in closing?
Well, it's one of the most exciting times actually in MPN history, that we have so many drugs which are out there being evaluated for approval, actually, to treat MPNs that may have curative potential. And that's exciting. I'm excited about rusfertide for patients who have polycythemia vera, that my patients who've been on the rusfertide trial have had very nice control of their hematocrits without having to use drugs like hydroxyurea. And it can be used in conjunction with meds that are cytoreductive, so that it seems safe in combination. So that's very exciting, and it looks like that's a drug that's really on the highway to approval, in my opinion. The BET inhibitor from Constellation is also that trial, phase 3 trial, has recently closed, and that data is going to be evaluated. It appears there's at least a subset of patients that appear to have a pretty remarkable response to this category of drugs. Not everybody. We have to figure out who the people are who are responders. But I think that, again, this is a drug which has moved from the entrance ramp onto the highway, and I'm excited to see what happens with that drug. Navitoclax, same story. The drug looks like it could be, again, promising for particular subgroups of patients. We have to figure out who those patients actually are. But again, it's moved from, it's moving from the entrance ramp to the highway. And, that's another drug which is out there in sort of the space for potential approval. We'll have to see what the data shows. There are BET inhibitors coming from other companies that are out in clinical trial, and it will be interesting to see where these go. There are other novel drugs that are in clinical trial. We don't really know the efficacy data yet, but we have enough drugs sort of juggling in the air. Merck has a drug which is an LSD1 inhibitor. we'll be interested to see what happens as those trials move forward. And Bezrami combinations, we'll have to see sort of what happens as those move forward. The new JAK2 inhibitors potentially in combination, not just ruxolitinib, is there an advantage? Is Rux really going to be the tried and true winner, or is it going to be one of the other JAK inhibitors, which is going to take precedence? We don't really know the answer to that question yet. So there's a lot of drugs out there that have the potential to alter the space in myeloproliferative diseases, and maybe delay that necessity for transplant for cure, and may have disease modifying effects that are important. So, we're in an exciting new era.
Extremely. It's just amazing to me how much attention and how much is going on. It's just fantastic. Thank you, thank you, thank you. I know you have a busy day, and I so appreciate you doing this. It's just all of the docs, the MPN docs are just amazing. And I hope to see you in New York for the 10th Annual Women in MPN Conference. I think I sent you that date. It's the 27th of September. And I just so appreciate you, Ellen, and I'll make sure you are there because you do such a good job. And
it's always such a nice event. So I think last year we had, for those of you that were able to join us, I think we had a really lovely Women in MPN event last year. And it was very collegial and really fun. So
yeah,
hope that you all can make it this year.
thank you again. We'll be in touch and have a lovely week.
You too.
Okay.
Come out. It's very gray here in New York.
It's great here as well.
We're having rain all week, so I'm looking for that spring sunshine.
Yes, we need sunshine. Okay. Take
All
care,
right.
Ellen.
Take care.
Bye now.
Bye-bye.